overview. My name is James Kelly. I am joined by my colleagues Rasheen Lundgren, Kurt Fire, and Ben Eddy. We're very happy to be here today and to present our Medicaid business process improvement plan. We believe that our actionable recommendations will allow you to better serve the public while also cutting your costs. I won't get too deep into the problem here because you are already very well versed in the situation. We have two competing agencies, the DOC, Department of Corrections, and DVS, Department of Veterans Services, who serve very different, distinct subsets of the population, and they are competing for funding to improve the way in which individuals are enrolled in healthcare plans. Now our goals are your goals because we're here to serve you. And to do so, we want to streamline your business processes. We believe by just making some minor changes, kind of tweaking the way that you do your business, that we will be able to make significant contributions into your, with regards to your productivity and the way that you operate your day-to-day business. To that end, we want to improve coordination among agencies. Specifically, we are going to be working with the Department of Community Health, and we want to make sure that there's an efficient line of communication between agencies within the state. We also want to improve customer service because as the state, you are a public organization and you want to serve the public and the people who live in your state. And finally, we're looking at potential cost savings. And that is a crucial factor for you and for us because we know that you have a balance, you have a budget to balance. That is a very crucial issue, and we believe that our recommendation will make it much easier for you to do so.
So we analyzed the data that was given. So we have a total of 173,000 veterans in the state that are currently enrolled in Medicaid. And they live in geographically diverse areas. Some are in rural, some are suburban, some in urban areas where they have more access to services. And they also have an existing relationship with their medical providers. So we have 2.4 million, which these veterans represent 7% of the total state Medicaid enrollees. And we took our data set and took an average, and we found out that veterans who are using Medicaid are costing the state about $205 per month, which comes out to $2,460 per year. So the total burden on the Medicaid budget is $426 million per year. And we also expect a 3% growth in terms of Medicaid enrollment with the veterans. And this is just outlining the Veterans Administration goals for the State Department. There's currently 90,000 veterans with an agency goal of reaching 360 in the future. So in looking at our prison systems, we're using $223 million per year for medical costs right now for 50,000 inmates. And right now our prison system is really at capacity. And that's an average of $4,460 per inmate. However, only 2,500 inmates had hospital stays. And from our data set that we were given from the department, we determined that our main cost drivers are those who had hospital stays that were over 24 hours from among those hospitalized. And this actually is only 1,750 inmates, which is about 70% of those 2,500 who had hospital stays. And the average stay was about 9 days, so it's fairly lengthy. So this is a population to focus on, 1,750 inmates that are costing $68,000 per year. So the opportunity here is about $119 million in cost savings.
All right, so what we have here is just a simple pie chart of the total Department of Correction healthcare costs. This is, the total number would be the 233 million for the healthcare. And the red side here is just the segment of the healthcare costs of those that stay longer than 24 hours. They compose 51% of the total budget, saying that only 3.5% of the total inmate population is taking up just over half of the total healthcare costs.
And this brings us to our recommendation. As my colleagues alluded to, the main cost driver within our prison system are the individuals, the inmates who are staying in hospitals for greater than 24 hours. So what we propose to do is we want to hire 2 full-time employees. They will be known as Medicaid enrollment specialists, and they will work with the Department of Community Health and have a specific line of communication with the prisons. And they're working specifically with that population, trying to enroll those individuals who are staying in hospitals in our prisons for greater than 24 hours. As far as some logistical facts go, we're looking to pay these full-time employees about $40,000 a year, including fringe benefits. And we're going to use that remaining $20,000 in funding for any sort of technological upgrades that they may need in their office, in office supplies, or any training. And the purpose of that funding is to give them the opportunity to do their job at their best ability. We want to give them the tools to succeed.
All right, so what we have here is a nice scattered plot of those 1,750 inmates who stay longer than 24 hours. As you see, we have a nice little trend line which follows that the more days you spend in the hospital, the more costs you incur. But what you also see here is there's a nice population up here that is incurring a lot of healthcare costs, and they're not staying that long. After further analyzing, there are people who have cancer. They're the ones that are having heart attacks. And we know that, sadly, as we all probably know too well, that cancer most likely comes back. You're more likely to have a heart attack if you've had one. So we need to concentrate on these people and get them onto Medicaid and off of our books.
So in order for our recommendation to work, we had to make a number of assumptions about facts that weren't provided to us in the case. So firstly, without Medicaid coverage, we assume that recidivism, which is the chances of someone returning to prison after already having been in prison, will be higher. We assume that hospitals will continue to subsidize 75% of the medical costs for those inmates that remain at the hospital for more than 24 hours. And we also assume that with the Medicaid expansion under the Affordable Care Act, a vast majority of these inmates are going to be eligible for Medicaid.
If they're at hospitals over 24 hours.
Yes, of course. So we also finally assume that 2 to 4 inmates a day is a reasonable and achievable number for each full-time employee to process. So regarding the potential benefits of our plan, we really wanted to emphasize the double bottom line of cost savings and public benefit. So from a cost perspective, we've really emphasized having the federal government paying for these inmates that are staying beyond 24 hours is a huge potential cost savings. But secondly, inmates can retain that Medicaid coverage once they are released from prison, which turns out to be a substantial public benefit. Because once these inmates are released from prison, that Medicaid coverage will allow them to be much more financially stable, which will reduce their recidivism rate. That's especially pertinent because 70% of these inmates struggle with addiction, 34% struggle with mental illness. So they could really stand to benefit from this Medicaid coverage. Our prisons are already completely full, so keeping people from returning to them is a huge benefit of this plan. And along these lines, in the New York Times recently, Dr. Fred Osher said for those newly covered, it will open up treatment doors for them.
All right. So one of our main dilemmas here between the two propositions was, with that $100,000, if we had 2 employees, where could we do the most damage to the budget? Where could we save the most money? And pretty much all things held equal. If we had 2 people in devoted just to the Department of Corrections, getting those 1,750 inmates onto Medicaid, they could save $65 million a year if they did the bare minimum of two enrollments a day. Whereas if we gave 2 employees to the Department of Veteran Services to have them get 2 veterans off of Medicaid and onto the VA plan, they would only be able to save $5 million a day. And the good thing about this is our estimates are very conservative of only being able to do 2 enrollments a day. If they can do 3, maybe 4 a day, that number is only going to get bigger. It'll literally be off the chart.
So in order to critique and improve our proposal, we tried to predict a number of criticisms and how we could lessen any fears that were presented to us. So someone might say that this proposal is a further burden on the federal government, which will lead to greater deficits. Well, we counter that with the policy of the Affordable Care Act is to provide health care to all. So that's the government's intention, and accruing a deficit is fine. Someone might say that $100,000 just isn't enough in order to process all the applications that we need to with the prison population. But we think that when the state sees that the potential cost savings are actually bearing fruit, that they could expand this program and provide Medicaid to all of the prisoners over time. Someone might say that there's a lack of public support and for using tax dollars to provide health care to prison inmates, but this, as we've already presented, the state prison system is going to become much more financially viable over time with this recommendation. And finally, from a PR standpoint, probably the biggest issue with our recommendation is people would see that veterans deserve more attention than prison inmates. And to that, we'd say the long-term savings of our plan are so substantial that the state could hypothetically spend those savings on veterans and help alleviate their problems as well.
So in formulating our recommendation, we kept coming back to the double bottom line. And ultimately, I think that the costs saved from our recommendation are substantial. They are in the millions of dollars per year. As far as public benefit, as my colleague alluded to some of my question, how is giving prisoners helping the public? Well, I think there are many ways in that, in how that will happen. And also, I think it's important to remember too, yes, that they have made mistakes in their life, they have done bad things, but everyone deserves a second chance. And we're giving them the opportunity to succeed. Recidivism rates will be lower as a result of them having healthcare coverage. They'll be better integrated into our society, and they'll better be able to contribute to our communities. And I think if that happens, then all of us will.
Thank you for your time.
Thank you.
Thank you. Well, I think you made an interesting case about the financial benefits. I'm a little bit confused about this FTE. So these would be DOC employees?
They would work with the Department of Community Health, but they would work directly with the Department of Corrections, enrolling the individuals who are staying in healthcare or in hospitals for greater than 24 hours.
Okay, so they're DCH employees.
Yes.
Correct.
But they're
Dedicated to.
they're dedicated full-time to just doing our DOC's enrollments.
Correct.
Now, I know DCH is already understaffed and underfunded. Is it really good use of resources to pay 2 full-time staff just to do these referrals when, as you pointed out already, they could easily be able to do that more just coming from the DOC referrals?
They actually, during our meetings with the DCH, they said that they, because of that, they would need extra staff to process an additional burden of the prison system. So it seems to meet their needs when we proposed the idea of 2 additional staff,
Okay, and it was 40 grand a year with your expected salary?
Yes.
including fringe
We
benefits.
did some research online of what people in that field, between Medicaid specialists and Medicare specialists, how much they make, and we came up with that number for wages and benefits.
Okay, so you could essentially fund someone, 2 people for 2 years or a year
A year.
a year.
It's a year projection for our estimates for the 65 million in savings.
And
So
then-
then after that, what next?
We're hoping that the results will be so evident, so successful, that the state will continue to fund these workers.
Well, we're pretty certain that there'll be a funding stream to actually expand the
Because
program.
each inmate that they get, each concentrated inmate that they get off
High risk.
one of the high-risk people, they're worth $68,000 a year. So if they get one a year, they're practically paying for themselves. And if we know that hopefully they can do more
In
than one a
Medicaid
year.
savings. So. Or, sorry, in
DOC.
DOC savings.
So 68K is just state funds, or 68 is 90% that federal funds?
No,
it's
that is
state
just the DLC budget
funds. State budget.
dedicated to healthcare
The
costs.
state budget.
And I had a question about the metric of processing two per day. So we would effectively be devoting two specialists who would enroll what looks like one person per day.
Four.
4 a day,
Four.
total.
Four
Yeah.
a day.
2 per person per day.
And that's a conservative estimate, the more that they could do. the better.
How did you derive the two per day estimate?
It's very conservative, but in our interviews, we heard numbers anywhere from 2 days to 60 days to process these applications. So we just wanted to be extremely conservative and say, worst case scenario, how many would they be able to process on average? Because some applications are going to take months to verify all the information and contact all the appropriate agencies, but some applications might take hours. So on average, we thought 2 per day, based on our interviews, would be appropriate.
We don't anticipate a long turnaround because none of the inmates, they'll be filing as single because their families who have benefits have already filed without them included as a member of the household. And they have no income, so there's no income to verify. So there's no process of submitting income paperwork. It's very straightforward.
So you want to enroll all prisoners on Medicaid even before they're in the hospital? So then you just said
That'd be a long-term goal. I would say we want to do at least the 1,700 that are the frequent visitors to the hospitals. We want to get them signed up first.
That's a sample. So that estimate was from a sample provided.
I don't think with our resources, we wouldn't be able to do all of them, all 50,000 in a year.
They would be enrolled when they arrive at the hospital. They would process the paperwork.
But that would
As
be
soon as-
after a year if there's more funds available for that to happen. Our main goal is to get the 1,750 signed up immediately, as fast as possible, because they're the ones that are 51% of the budget.
And is this a manual process? Talk to me a little bit more about how that referral actually happens. As you know, we're building a new ID system. So what role would technology play in this?
So with the prison system, I mean, there's two different ways. You can use the IT platform if you're in the general public, but there's also usually a telephone call that's available as well. And so the workers would primarily be communicating with the inmate through telephone services.
So they'd apply with a phone?
There'll be a dedicated phone line, one that is specified at each prison for calls with the DCH workers and the Medicaid division.
Just trying to wrap my head around the 2 applications per day and the processing times. So I'm wondering, those individuals want to be doing all of the follow-up. It's a 60, 90-day processing time, but they wouldn't be they're not wrapped up full-time for the 90 days. Could you go to the issues and risks slide? Yeah, thanks. So, Okay, so you did talk about, on the funding issue, the 100K a year, 40 would be fully loaded cost per FTE, plus 20K in training for the first year. Then, I think in response to the question, you're saying that you would be looking for general revenue funds for some duration into the future to fund those positions, right?
Correct.
Well, we'll see enough savings through the Medicaid program, that something would have to be arranged as far as how to reinvest the savings.
So it's savings for the DOC, not actually savings for Medicaid.
I'm sorry, it is savings for the DOC, I apologize.
Correct.
So, but they'll be able to reinvest the funds into the process of enrolling new inmates or redirecting the funds elsewhere, if that's the governor's decision.
What is the relationship between the DOC and DCH right now?
As you alluded to earlier, the Department of Community Health is very overburdened, and so there's not as much of a relationship as we would like to see. So we think that by adding these 2 full-time employees, then that will really increase the communication between the agencies where they're able to act more efficiently.
And the other question I had on the issue side was around the lack of public support. Not questioning that, but the statement you're making is the prison system will become more financially sustainable over time. We're talking just about healthcare here, right? When you're talking financially sustainable over time, we're not talking about prison operations, supply chain. So you are very targeted. Or are you telling us that
Because there's such a large burden on the prison system by having to pay for the hospital stays, the $65 million that is projected to save in the first year is a substantial amount of funding available that has not been previously available.
So you would propose then to the governor that the DOC keeps that $65 million rather than the governor sweeping that $65 million and allocating it to another program?
That's up for the
That's
governor.
We
beyond
have
our
not
purview.
specified that, that's just an option.
Okay.
It's an
Okay.
option. We're not,
Okay, so I think I'd be a little careful then about the statement that the prison system will be more financially sustainable.
Okay. It's an
Given that we
assumption.
don't know where those funds are gonna go. If we're gonna pull back into the general revenue fund, or is it gonna be made available to DOC?
We're a little over.
Okay, the one other question, it's not really a question, it's more of an observation, is you used the term recidivism a couple of times, and obviously, I think you were using recidivism in a healthcare sense, right, with respect, or you weren't actually proposing recidivism within the DOC world as a term of art, that somehow by having better healthcare, prisoners will be less likely to commit other crimes.
I think that would be true in those that have mental illness. Those who are unable to possibly get their medication, if they are now on Medicaid and have a steady stream of their medication, I think they absolutely would commit less crimes.
Just a comment that when you're making statements like that, be very careful how they're couched and make sure that you've got a lot of facts to back it up. Because as you're aware, in the corrections where recidivism is a very hot topic and continues to be a very hot topic. If you're going to make that statement, make sure that you have a lot of data to back that up.
Fair enough.
Because that was one area in the presentation that kind of threw me a bit about how you made that leap. to
Right,
yeah.
recidivism.
Right. Obviously, when it comes to cancer or something like that, yeah, Medicaid isn't going to stop.
Yeah.
Yeah, you're right.
All right. Well, thanks a lot.
thank you.
Thank you.
Hope
Thank
it
you.
was an experience.
Was.
All right, cool.
Thank you.